good afternoon, good morning, and good evening to everyone. Thank you for joining this WHO EPI-WIN Wednesday webinar on the topic of Zika virus, learning from the past, preparing for the future, hosted by WHO EPI-WIN team. For those new to EPI-WIN, this is the WHO Information Network for Epidemics for Science and Knowledge Translation in Health Emergencies. With these EPI-WIN webinars and the associated digests, our goal is to translate science in accessible, understandable, and relevant ways for evidence-informed actions and decisions in health emergency preparedness and response. Today, we have a great panel to discuss Zika. I will give a brief introduction. Our speakers today are Dr. Sylvie Briand, Director for Epidemic and Pandemic Preparedness and Prevention at WHO, Dr. Maria van Kerkhove, Unit Head at the Emerging Diseases and Zoonosis Unit in WHO, Dr. Diana Rojas Alvarez, Technical Lead for Zika and Chikungunya in the Emerging Diseases and Zoonosis Unit at WHO, Dr. Sudat Samarawera, Regional Consultant on Arbovirus within the WHO Regional Office for Southeast Asia, Dr. Judith Wang, Director in Microbiology and Molecular Epidemiology at the National Environment Agency of Singapore, Mrs. Thais dos Santos, Advisor on Surveillance and Control for Arbovirus Diseases Neglected at the Tropical and Vector-Borne Diseases Unit, Pan American Health Organization, and Dr. Ricardo Jimenez, epidemiologist and professor of tropical medicine at the Federal University of Pernambuco in Recife, Brazil. The Q&A will be moderated by Dr. Diana Rojas Alvarez. Some housekeeping now. This webinar is being live streamed on the EPI-WIN YouTube channel. This webinar is being recorded, and afterwards the recording will be available from our website. The address will appear in the chat. Interpretation is available today in French, Spanish, Portuguese, and Arabic. Plus, interpretation is in Hindi, Chinese, and Russian are also available through artificial intelligence. Please go to the interpretation globe icon to access and select the language. We invite you all to post your name, location, and organization in the chat box. We would love to hear where you're joining us from. Please add any questions you may have to the Q&A box, not in the chat, so that we can easily reply to your questions. Without further ado, I will hand the floor over to Dr. Sylvie Briand for the welcome to the EPI-WIN webinar on the topic of Zika virus, learning from the past, preparing for the future.
Thank you very much, Dr. Agnese. And good morning, good afternoon, and good evening, everyone. Welcome to this EPI-WIN webinar on Zika virus disease. You may wonder why we chose this subject for today, but maybe you remember as well the tragic epidemic of Zika virus in Brazil in 2016. Personally, I still remember with emotion and sadness those poor babies that were born with neurodevelopmental defect and their mothers who had to carry them and to try to alleviate their suffering. It has had also a terrible impact on families and communities during this year. So Zika for us is an important public health risk and problem. And that's why we thought it was important also to bring together different experts across the world to talk about it. Also, you need to know that Zika is a virus that is transmitted by vectors, and those vectors are Aedes mosquitoes. Those mosquitoes are very broadly distributed on Earth, especially in tropical areas, but with the climate change, I mean, this distribution is slightly changing, and also we can see transmission through Aedes mosquitoes also in temperate countries. And you may also remember that recently we had a huge outbreak of chikungunya in Uruguay and Paraguay, and we also have currently dengue in Argentina. Those diseases, dengue, yellow fever, chikungunya, are also transmitted by Aedes mosquitoes. So for us, this is why it's important that we all learn more about the disease, how they are transmitted, how we can protect ourselves against them. And I would like to thank really much the experts and my WHO colleagues joining this webinar today to share their knowledge, their expertise and experience on this disease, because this will help us to be better protected. And so I thank you all also attending this EPI-WIN webinar, because together we can make the world safer by knowing our risk and managing them without unnecessary fear, but with adequate preventive action. So thank you very much, and over to you, Agnese.
Thank you, Dr. Sylvie Briand, for this amazing welcoming. And now I give the floor to Diana to start presenting about Zika, and also to start moderating the session. Over to you, Diana.
Thank you very much. Good morning, good afternoon, and good evening, colleagues. Let me start showing a video with the overview of Zika. So we all remember the basic information about Zika. Please confirm that you can see. Give me 1 second. Can you see the video, the image?
Yes, we can see it.
Okay. Can you hear it?
No, not yet.
Okay. Zika virus is spread by Aedes mosquitoes, which are found in nearly all the continents and by mostly during the day. Zika virus can be transmitted sexually between people and from mother to child during pregnancy. Although cases of Zika virus disease have declined globally since 2017, they are still occurring at low levels in several countries in the American and in other regions. To date, 89 countries in territories have current transmission by Zika virus transmitted by Aedes mosquitoes. Most infected people do not have developed symptoms. They can have rash, fever, red and itchy eyes, among others. Some infected patients develop serious neurological conditions like Guillain-Barré syndrome with progressed weakness, inability to breathe, and requiring ventilation. Some women infected during pregnancy have babies with a smaller head than normal, that is called microcephaly, and also Zika congenital syndrome and problems with preterms and miscarriages. Currently, there is no specific treatment or vaccine for Zika virus infections or disease. Infected people with mild symptoms should get plenty of rest, stay hydrated, and treat symptoms with medications for rashes and fever. If symptoms worsen or if patients experience numbness, increasing muscle weakness, or difficulty breathing, they should seek immediately medical advice, care. If pregnant women have traveled to or live in areas with Zika transmission or develop symptoms of Zika virus infection, they should seek medical attention for laboratory testing, information, counseling, and other clinical care to prevent Zika virus infection. People in areas where the virus is circulating should take actions to avoid those mosquito bites during the day and early evening. This is especially important for pregnant women, women of reproductive age, and young children. Helpful strategies, including wearing light-colored clothing that covers much of the body as possible, using physical barriers such as window screens, closed doors, and windows, and applying insecticide repellent to skin or clothing. Aedes mosquito breeding sites should be eliminated by covering water storage containers, removing standing water in flower pots, and cleaning up trash that may serve as reservoirs for mosquito reproduction. People with Zika virus, particularly pregnant women and their sexual partners, should receive information about the risk of sexual transmission in order to prevent possible adverse pregnancy and fatal outcomes. Sexually active people should be counseled and offer a full range of contraceptive methods so they can make informed choices about whether or when to become pregnant. The World Health Organization supports countries with Zika virus transmission to reduce and control the disease in various ways under the Global Arbovirus Initiative and other synergistic strategies. Support includes development of evidence-based technical and clinical guidance, outbreak response activities, coordination of laboratory confirmation through collaborating centers, and improved surveillance. We can all play a role to reduce the impact of Zika. Protect yourself, your loved ones, and your community by taking steps to prevent mosquito bites, sexual transmission, and visit your healthcare provider for counseling and care if you think you have been infected with Zika virus. Well, thank you very much. So now I will give the floor to Dr. Maria van Kerkhoff, who is the unit head of the Emerging Diseases and Zoonosis, who is going to talk briefly about Zika as part of the unit of Emerging Diseases and Zoonosis. Maria, Dr. van Kerkhoff, over to you.
Thank you, Diana, and thanks for your adaptation with that video. That was wonderful. So I'll be very brief so we can get on with the webinar. So most of you know that Zika has not been in the news since 2017, when the public health emergency of international concern linking Zika with microcephaly was ended. However, it is circulating in many countries and regions. As you've seen in the video, most of the Zika infections are asymptomatic or mild, which makes it very challenging for health systems to actually detect the virus, which poses challenges in providing the right types of interventions to either prevent infections or care for those who are infected with Zika. On this EPI-WIN seminar, we want to provide an opportunity to update you with about the current epidemiology of Zika virus in the regions where it has been detected, and bring awareness to all of you about the other areas in which Zika is still circulating. Healthcare workers should be considering Zika as a potential diagnosis in residents, or those who have traveled to areas where these viruses are transmitting by the Aedes mosquito vector. And remember that remember those who are most at risk for complications of Zika infection, and those are pregnant women and their partners. Many people associate Zika with Brazil, but today you will see that it's not only in one particular country, but there are other areas in which Zika is circulating, and we want to raise attention to this. It's also important not just to know what do we know about Zika and its circulation, but what are we doing as the World Health Organization with our partners to prevent, detect, and respond to Zika and other arboviruses. As you saw from the video, we are working on a global arbovirus initiative, which is targeting Zika along with chikungunya, yellow fever, and dengue to provide an integrated approach, bringing partners together to tackling these arboviruses. And specifically, these activities include monitoring virus transmission, Zika virus transmission globally, so that we can anticipate outbreaks and prevent large outbreaks from happening where that may be possible, to reduce epidemic risk through strengthening early detection of transmission to improve response to Zika outbreaks, developing guidance for surveillance, clinical management, and follow-up of Zika virus complications, enhancing environmental and vector surveillance and strengthening cross-sectoral vector control, developing risk communication and strengthening community engagement and resilience so that we can prevent as many infections as possible, updating the public health research agenda of Zika because we don't know everything about this virus and the disease that it causes, and together with other arboviruses to support the development of innovative countermeasures such as diagnostics, therapeutics, and vaccines, and vector control tools. We are hoping to work with our partners and provide a leading role in research, identifying the priority areas for Zika research, such as understanding the risk of microcephaly and the spectrum of congenital Zika syndrome. And for all of this to be successful, we worked with many partners and stakeholders around the world, and we will need to continue to do this as we go forward. So back to you, Diana, so we can continue on with the EPI-WIN seminar.
Thank you very much, Maria. And well, let's get started then with our invited speakers. Now I will give the floor to Dr. Sudhat Samarawera, our regional consultant on arbovirus in the region of Southeast Asia. Dr. Sudhat, over to you.
Thank you. I will share my slides. Can you see my slides?
Yes, but we are not seeing them in presentation mode. We can see all your desktop.
Okay.
Please let us know if you want us to share it for you.
Can you see it now?
Yes, we can see them. Over to you. Go ahead. Thank
Okay,
you.
thank you. The Southeast Asia has 11 countries. Out of that, other than Bhutan, DPR, Korea, Nepal, and Timor-Leste, all other countries have reported existence of Zika virus infection in those countries. In Bangladesh, the first case of Zika virus infection was reported in 2016 in a sample collected from a 67-year-old male who had never been overseas, that implying that local transmission of Zika. In India, it is reported in as early as 1954 by National Institute of Virology, Pune, by examining samples, blood samples collected, and they reported 16.8% of seropositivity among these samples. But you have to interpret these results very cautiously because there's a high cross-reactivity with dengue virus and other flaviviruses. India has established the sentinel surveillance in 2016. In 2017, reported first cases afterwards in Ahmedabad, Gujarat, and Chennai. And a largest outbreak was reported in 2018 with 283 cases in Rajasthan, Gujarat, and Madhya Pradesh. Again, in 2021, 22, and 23, cases were reported in different parts of the country, Maharashtra, Karnataka, and lately Mumbai. In Indonesia, 1981, first case was reported in Central Java. Then 2013 to 2015, sporadic cases has been reported among travelers returning from Indonesia. As well as in 2014, seroprevalence survey in 14 provinces has shown that among 1 to 4 years, 9.1%, and among aged 5 to 9 years, 9.2% seroprevalence of Zika virus infection. Again, in 2016, Zika virus has been isolated in a 27-year-old male resident in Central Sumatra. In Maldives, laboratory confirmed cases of Zika virus disease was reported in 2015 in a 37-year-old Finnish male who returned home after working for 6 months in Maldives. Soon after returning, that he developed flu-like symptoms, rash and eye pain, and positive for Zika virus in with a PCR in urine sample, but not in serum. At the same time, dengue virus IgG and IgM positive, but dengue NS1 was negative. But the demonstration of Zika virus by PCR in urine has confirmed this as a Zika virus case. Again, in 2016 and 17, 3 cases were positive out of 651 cases tested. Thereafter, no cases has been reported in Maldives. In Myanmar, after analysis of 162 samples from patients, asymptomatic people from patients and asymptomatic people from 2004 to 2017, confirmed Zika virus infection among 4.9% of the patients with dengue symptoms and 8.6% of asymptomatics. In Sri Lanka, testing 595 samples collected from suspected dengue patients from 2017 to 2019 in 2 tertiary care hospitals has shown that 2.9% of the samples were confirmed as having Zika virus infection. This research has been published in 2023. In Thailand, it is believed that Zika virus infection is endemic, having a peak in June and July, coinciding with the wet season or rainy season in the country. As of 21st August this year, 241 cases has been reported from 22 provinces, with the highest number of reported from the one single province with 76 cases. This 2016 to 2022 database shows that out of these 241 Zika virus infected pregnant women, 3 delivered babies with microcephaly, and also has demonstrated congenital abnormalities and also Guillain-Barré syndrome with typical presentations of Zika virus infection. So you can see that there are different type of presentations in countries. There was a survey, arboreal surveillance and control capacity survey among countries, and out of the 11 countries, 10 countries in the Southeast Asia region responded to that, and available laboratory capacity for diagnosing Aedes transmitted arboreal diseases. You can see that dengue virus testing is fairly robust in almost all countries out of these 10 countries. It follows by the chikungunya virus. Most of the countries are having some sort of diagnostic facilities. But when you go into the Zika virus, you can see that most of the countries are poor in that aspect. So that means that most of the countries don't have the capacity at the moment to test, or there's no testing mechanism going on in these countries. Only sporadic cases, mainly by research activities, has been reported. Although serological studies suggested the presence of Zika virus infection in the Southeast Asia region, since as early as 1950s, the reporting cases are sporadic. Serological assays are used in the most of the time identification of the Zika virus infection. They may be cross-reactive with the other circulating flaviviruses like dengue virus and Japanese encephalitis virus. Therefore, interpretation should be very cautious. Underreporting or low-case detection may occur because of the non-availability of Zika virus infection surveillance system, and as well as that not testing for that. Again, the less likely to be Zika virus infection to be included in differential diagnosis because if it is a rare disease at the moment. And the asymptomatic, mild and afebrile or atypical presentation of Zika viruses often happens. So because of that, there may be missed cases. In this context, the epidemiology of the Zika virus and the disease burden in the region is poorly understood. There are many more to be done to understand the correct or the clear burden in the region and its impact on the health of the people in the region. So I would like to acknowledge Dr. Aya Yajima, Dr. Hannah Brindle, Dr. Yuka Junai, and Dr. P.K. Amkranath Babu for supporting to prepare my presentation. Thank you.
Thank you very much, Dr. Sudat, and thank you very much for this update from the Southeast Asian region on the epidemiology of Zika, because it's very important to know that Zika is still circulating. And thank you also for highlighting the main challenges and limitations that your region and I'm sure other regions have. Thank you very much. So now I will give the floor to Dr. Judith Wong, the Director of Microbiology and Molecular Epidemiology of the National Environmental Agency in Singapore, who is going to talk about case, entomological, and wastewater surveillance of Zika, a multidisciplinary approach. Dr. Wong, over to you.
Thanks, Diana. Can everyone see my screen?
Yes, we can see your screen. Go ahead.
Thank you. Good morning, good afternoon, and good evening, everyone. And thank you very much, WHO, for inviting us to share an update of the Zika situation in Singapore and how the National Environment Agency, with the Ministry of Health, have employed a multidisciplinary approach of case, entomological, and wastewater surveillance for Zika when we had a number of cases recently. In Singapore, we first had a reported case and outbreak in 2016 to 2017, when approximately 500 cases had been reported. Ever since then, we only had one very small cluster in 2019 and a couple of sporadic cases over the years. However, this year, in 2023, we had about 22 cases reported, with one cluster of 15 cases in northeastern Singapore. Hence, to monitor the situation in the area, we conducted enhanced case, entomological, and wastewater surveillance. For cases, healthcare practitioners and the community were alerted to look out for symptoms and to take precautionary measures. We also complemented case surveillance with wastewater monitoring to understand whether there were cases in the community. We hypothesized that we would be able to detect Zika traces in wastewater, as we know that the virus is shed in urine. Additionally, we also screened Aedes mosquitoes caught in the vicinity to understand the risk of transmission. The results then collectively informed risk communications, vector control operations, and further surveillance. Over here, this map shows the spatial distribution and area of cases where the positive cases were reported, shaded in orange. The red and green dots indicated the locations of positive and negative mosquitoes trapped, respectively. The solid lines bounded in purple, green, and blue of increasing concentric areas were where we have deployed wastewater autosamplers to conduct wastewater testing for the area. Collectively, our results showed that when positive cases peaked in the cluster area, as indicated in the blue bar chart, we also detected positive wastewater signals in the cluster, as indicated in the blue solid line in the graph below. We also detected positive mosquitoes during this period. Additionally, for mosquito samples, we dissected them whenever possible and tested them for Zika. And we found that the Zika detections were both in the head and thoraces, as well as the adult man. So this implies that the vectors are able to disseminate Zika. And we found positive detection in both Aedes aegypti and albopictus. Thankfully, the subsequent waning of signals after the peak detection in May and the waning of signals in June suggested that the control measures were working. So we also similarly sampled the wastewater from other areas across the country, and thankfully there was no Zika detected. This was also similarly observed when we tested mosquito samples collected from areas with sporadic cases reported. So this island-wide surveillance was really made possible because we leveraged on existing monitoring systems. For wastewater surveillance, we tapped on our existing COVID-19 surveillance network, while for mosquito surveillance, we tapped on the Gravitrap monitoring network to monitor the Aedes aegypti and Aedes abundance. In terms of phylogenetic analyses of the positive cases and mosquitoes, we found that the Zika strain in 2023 is genetically distinct from previous strains reported in Singapore, and this is indicated by the lineages in blue fonts. And the current strain was genetically closest to viruses previously reported in Philippines in 2012 and 2016. The difference in the distinction in the lineages further supports our understanding that there's no continued transmission of Zika in Singapore, even though we experience local transmission from time to time. On a similar note, seroprevalence assays done after the large outbreak in 2016 also showed that only about 3.3% of the population were Zika seropositive, and of these, only 34% were confirmed to have neutralizing antibodies. So in summary, our study shows that Singapore had no continued transmission of Zika. However, with the low population immunity and the presence of competent vectors, this does put us at risk. Therefore, this necessitates a comprehensive surveillance of case, vector, and wastewater surveillance to monitor the situation. And by doing so, by tapping on existing networks, we were able to swiftly zoom into the cluster within 3 days and operationalize our surveillance efforts. Notably, we have also described a new approach for wastewater monitoring as a non-intrusive monitoring to understand the spread of Zika. And this is especially important for Zika because we know that infections are typically mild, but may cause severe disease in a vulnerable group. So with that, I end my presentation, and I would like to thank Associate Professor Ng Yi Ching for guidance, and she's our group director, as well as colleagues in our agency, including Wilson, Chandita, Martin, and Chewing for their help. Thank you.
Thank you very much, Dr. Wong, for presenting the case study of Singapore and how the multidisciplinary approach can help to control clusters of Zika viruses in different countries. So now let me give the floor to Thais dos Santos. She's the advisor on surveillance and control of arboviral diseases in the neglected tropical and vector-borne disease unit at the Pan American Health Organization. Thais, over to you.
Thank you so much. There we go. Thank you so much for the introduction, and thank you so much for the invitation. It's a pleasure to be here with this wonderful speaker panelist. I will speak today a little bit about the experience of the Americas with Zika virus, which is a little bit more recent than what has been mentioned previously by the previous speakers. The first detection of Zika in the region was in 2014 in the Pacific island of Easter Island, which belongs to Chile. It was concurrent with an epidemic that was happening in French Polynesia and other Pacific islands at the time. After that, in 2015, early 2015, clusters of rash-like illness were started to be detected in the in the northeastern states of Brazil. About 7,000 cases had been detected in February and April, but it wasn't until April 29th of 2015 that the first lab confirmation came in. These cases were coming in as dengue-like, but negative for dengue. And in Easter Island, we've been told that initially they thought it was an epidemic of some sort of allergy because it was an itchy rash, yet for very few of the cases presented with a fever. So it took a little while to figure out exactly what the etiologic agent was. But by early 2015, it was clear that it was Zika virus. And just a few days after, PHEIC issued its first EPI alert on Zika virus infection, providing guidance to countries, giving recommendations for surveillance of Zika, case management, and prevention and control actions. And you can find that in the PHEIC website. And I've included the link here, but I'm happy to share those subsequently as well. Just a few months after that initial detection, countries, particularly Brazil, reported an association between Zika virus infection and Guillain-Barré syndrome. They had, in a short amount of time, detected 26 cases of Guillain-Barré syndrome that also had a confirmation of Zika virus infection in the state of Bahia. And then a few months after that, we saw clusters of microcephaly, especially reported in Brazil, and associated with Zika infection. So as a point of comparison, from 2010, in the 5 years between 2010 and 2014, Brazil had detected 163 cases of microcephaly, whereas during this period of Zika transmission, 3,530 cases of microcephaly had been registered. And as you all know, by February 1st of 2016, both the neurological disorders and neonatal malformations led to the declaration of a public health emergency of international concern. So here I have sort of a consolidation of the three major arboviruses that circulate in the region of the Americas, and I have them here by year, just to illustrate the point that the region of the Americas, it has all of the necessary factors for good transmission of, sadly, of Aedes borne arboviruses. In the lowest bar you see here is the cases of dengue. 2023 has been the so far, and the year's not even over, the year of the highest case count of dengue so far. But after its initial introduction, you can barely see Zika in 2014, because Zika here is represented with the darkest blue, because it was just a few cases reported in Easter Island. But after that detection in Brazil in 2015, you see there a thin line, and in 2016, you see a broader line. And we'll be able to look at that with a little bit more detail in subsequent slides. But I just wanted to show to you that how complex it is that these three arboviruses are circulating in concert, and particularly with the case of Zika and dengue, both closely related flaviviruses, this represents some diagnostic challenges as well. The other point I wanted to highlight here is that in the 2 years post-Zika, look at what happened to dengue fever in 2017 and 2018, which may have something to do with this close relation of these flaviviruses. But we had a sort of nearly 80% reduction in the case counts reported for dengue fever, which obviously then came back and bounced back really quickly. 2019 up until this year had been the year with the most dengue cases reported. So, but in this context, from 2015 to this year, Zika case virus disease represents a little bit under 6% of the reported cases of arboviral diseases. So by up until October 2015, in the continent, obviously not including Easter Island, because continental Chile had not reported any cases and still has not reported any cases of local transmission of Zika virus. But we had only Brazil, and then between October and December, 12 additional countries reported local transmission, and then the subsequent 3 months, 20 countries, 7 countries, and by now 48 countries and territories have reported local transmission out of the 52 countries and territories in the region of the Americas. Here you see the cases, the countries that have the report the highest case burden. It's 89% of the cases reported in the region are concentrated in these 10 countries. Although Brazil reports the highest number of Zika cases, it ranks 4th in cumulative incidence with 57 cases per 10,000 population. And here you'll see a more detailed week by week case report of Zika virus infection, and you see that the bulk of the transmission happened in late 2015 and the first semester of 2016. And the subsequent decrease is really concerning because while it could represent a decrease in transmission, as many of you know, Zika is a disease that's difficult to survey because it has very non-specific signs and symptoms, and a good proportion of the cases show no clinical manifestations. And so the passive surveillance systems are not able to adequately capture. And the other challenge was that at the end of the declaration of the end of the public health emergency of international concern, we saw a very important drop off in notification too. So while this decrease may very well be also a decrease in the number of cases that were detected, there are also some artifactual things in terms of reporting that may represent that. But since that time, our transmission in the region has remained consistent, but at much more lower levels than what was observed in 2016. So far, we've had about 1 million cases. Only 27% of those cases have been lab confirmed, but the proportion of cases that are lab confirmed varies between 8 and 35%. For the last couple of years, it's been between 8 and 9%, which has a lot of opportunities for intervention and improvement, which we can discuss during the Q&A. And the highest incidence occurred in 2016 with 67.5% per 100,000. I'm not going to spend a lot of time here, but I wanted to include this for you here as a reference. It's the case definition that we've updated and we've been using since 2022, based on a systematic review that we conducted of the literature, based on all of the publications that have come out in the region, and since the French Polynesia epidemic, and I welcome you to peruse this later on, both in the slides and in PAHO's website. So to conclude, with except of Canada and mainland Chile and Uruguay in the south of South America, all countries and territories in the region have reported local transmission. We had the highest transmission in 2015 and 16. And despite a reduction in 2016, we really need to maintain this continued information sharing at sort of the same levels that there were. And I think this is of particular concern because every year, if this low transmission is in fact real, as low as it has been reported, then we're accumulating susceptibles every single year. So we need to stay especially vigilant to make sure there's not a new epidemic in the near horizon. And the other thing that I wanted to throw here for us to consider is how important it is for us to link the surveillance of acute Zika infection with the neurological syndromes. And those surveillance systems are two streams that are not necessarily communicating well everywhere. So that's a challenge that we've had in the region as well. And the issue that I brought up briefly about how important it is to have both adequate and sufficient lab diagnosis for the timely detection of Zika in a way that guides control actions. And that's all I have. Thank you so much.
Thank you very much, Thais, for this great presentation and the update on the epidemiological situation of Zika in the Americas. So without further ado, so we can have enough time to go through all your questions. Please keep putting your questions in the Q&A, and we are going to try to address them and discuss them at the end of the presentations. I will give the floor now to Dr. Ricardo Jimenez, who is an epidemiologist and professor of the Tropical Medicine Federal University of Pernambuco in Recife, Brazil. And he's also he's going to be speaking on behalf of the WHO individual patient data meta-analysis of the Zika cohorts that were built during the public health emergency of international concern to understand better the clinical symptoms and following up all the babies back then with microcephaly and congenital Zika syndrome. So let me give the floor to Dr. Ricardo Jimenez. The floor is yours.
Okay, first, I'd like to thank you very much for the opportunity to participate in this panel. And I'll be updating you on the activities developed by the WHO Zika Consortium and by the Zika Brazilian Cohort Consortium, mainly on the individual participant data meta-analysis that is being developed by each of these two consortia. Next slide, please. Let's start first by the WHO consortia. The objective of the IPD meta-analysis are, first, to estimate the absolute and relative risk of all these adverse outcomes related to Zika virus infection during pregnancy. Second, to identify modified factors of this association. Third, to decompose the total effect of Zika virus infections during pregnancy in 3 axes, meaning the direct effect of Zika virus, the indirect effect of Zika virus, and the effect of the interaction of Zika virus and the modifying factors. And fourth, to develop and validate a risk prediction tool to identify women at a high risk of having children with adverse outcomes after the Zika virus exposure during pregnancy. Next, please. So the individual participant data meta-analysis that is being developed by the World Health Organization is the most comprehensive one. It gathers 64 sites representing 22 countries and territories, and it pulls the individual data of 30,000 pregnant women, of whom about 11,000 are Zika virus positive, in a total of 18,000 children, individual data of 18,000 children. Next, please. Where we are now in relation to the WHO IPDMA meta-analysis. So first, we started by writing a protocol. It was done in 2019. Then we organized ourselves in working groups, and we started building a master code book, first with 200 variables, and then it was expanded to 900 variables, of which 700 are considered to be essential. We moved them to data harmonization, data imputation, and data analysis. And it was done in 2 steps. In the first steps, we used the pilot data sets, 10 pilot data sets, and then we expanded, adding about 20 more data sets, and we went through all these steps again. Which are the products that we have so far? So far, we have published the protocol. We have our paper on the metadata survey accepted for publication, and we are writing down about the 3 social science papers and the manuscript of the analysis of the 33 data sets that we have already analyzed and discussed the data. And the next step will be to add to what was done about 30 more data sets, and we'll be able, with this information that will be added, to meet the objectives 2, 3, and 4. Next slide, please. Let's move now to the Zika Brazilian Cohort Consortium. So the objective of the IPD meta-analysis of the WHO of the ZBC consortium is to estimate the risk of adverse outcomes among offspring of women with RT-PCR confirmed Zika virus infection during pregnancy, and to explore heterogeneity between studies. Next slide, please. The ZBC consortium grouped 13 cohort studies and about 15,000 women from all Brazilian regions in which Zika virus was epidemic. Next slide, please. The results we have so far are that we have the results that we have so far are that we have about the frequency, the absolute risk of microcephaly is about 2.5% if considered at birth or at first evaluation, and about 4% if we consider any time at the follow-up. The risk of brain images was higher. It was about 8%, mainly calcification and ventriculomegaly. Next slide, please. The risk of neurological outcomes was higher, about 20%, and the risk of ophthalmological and audiological outcomes was about 5%. If we consider the overall risk, meaning the overall risk, the risk of presenting at least one of these abnormalities, microcephaly, neuroimaging, neurological, or ophthalmological abnormalities, is about 30%. Next slide, please. There's a point that I'd like to call your attention, is that we found an association between microcephaly and between brain image abnormalities after birth, with the timing of infection in pregnancy being higher to the first trimester of pregnancy. And another important point is that we found no association of microcephaly with level of education, which is a proxy of socioeconomic condition, no association with race, and no association with the region of Brazil in which the study was conducted. Next slide, please. So what this study adds to what has been published before? It is important because it shows that about 1/3 of live-born children with prenatal exposure to Zika virus infection during pregnancy will present at least one abnormality compatible with congenital infection. It also shows that birth evaluation may underestimate the risk of Zika virus-related microcephaly, as microcephaly may occur postnatally, and it shows that the risk of Zika virus-related microcephaly is relatively homogeneous in relation to the region, in relation to the level of education, and in relation to the race of the groups considered. Next. What are the implications of the studies? The main implications are that it shows the need of a multidisciplinary health team to assist these children due to the complexity and diversity of the signs and symptoms that were observed. It shows the need to study the long-term consequences of the Zika virus infection during pregnancy, as these children are now reaching the school age and more subtitles or normalities could be detected using more sophisticated neurodevelopment tools. It indicates the need to continue developing Zika virus diagnostic tools that could be more affordable and accurate, and that they should be used for early detection of circulating Zika virus in community to try to avert new epidemics. Remembering that, as was previously informed, we are accumulating susceptible individuals. There is still no vaccine, and disease surveillance in relation to Zika is difficult. Next, please. Thank you very much for the opportunity to give this talk.
Thank you, Ricardo, for joining us in this webinar and updating us in all the most current information as a result of the meta-analysis of the different cohorts. So, well, we have good timing for discussion and to reply to some of the questions that have been posted. So let's get started. Let me start with a question here about what is the current situation of Zika in Mexico, and if it is still a concern. Thais, this question is for you. Over to you.
Thank you so much. I mean, we haven't had a cause for alarm for Zika this year. This year's been surprisingly low transmission. I mean, much lower than even compared to last year, even though concurrently we're having epidemics of both dengue and chikungunya. The Southern Hemisphere season of transmission just ended. It's the first semester of the year, and we had exceptionally high levels of both dengue fever, with the highest year on record so far in terms of case counts, but also a really high level of cases of chikungunya, with a pretty important epidemic in Paraguay, and then to a lesser extent in Argentina, Bolivia, and Peru. But it's worth noting that in this context, we've had really low transmission of Zika. It continues to transmit, but you know, many countries are running trioplex assays where in a single run, they're able to detect whether a specimen is positive for Zika, chikungunya, or dengue. So while we realize all the complexities and the challenges of surveying Zika with passive surveillance systems, I think if we were having a massive epidemic, we would be able to detect it. So this year, fortunately, has been a year of very low transmission in the entire region, including in Mexico. Over.
Thank you very much for your answer. And I will add that Zika is co-circulating with other arboviruses in many of the regions. And as it was mentioned in many of the presentations, most of the infections are asymptomatic. So they do not develop symptoms. So they do not go to the healthcare facility or to the closest hospital to get a diagnosis. So with Zika, what we can see is that it might be circulating silently without being detected. So that is something that you should keep in mind. So if the mosquito is there and they have been reported transmission, just take the precautions of wearing long sleeves and light colored clothes while you are if you live in an endemic region, or if you are traveling to an endemic region, and use mosquito repellent to prevent mosquito bites. I will go through another question. Dr. Sylvie Briand, are you still on the webinar? There is a question for you. Could Zika virus be responsible for the next pandemic? Or maybe Dr. Maria van Kerkhove.
I don't know
can
if
reply.
I don't know if Sylvie is on. I don't think she is, but
Okay, so Maria, do you want to take that one?
I mean, yeah, I can answer that. I mean, the answer is, of course, yes. Or it could be a virus. I mean, a lot of people think that pandemics are caused by respiratory viruses or respiratory pathogens because of the way they efficiently transmit between people and how these pathogens pass through the air. But you could have a pandemic that is caused by a vector, transmitted by a vector, like Aedes aegypti, and like we've seen with microcephaly. Remember, with Zika, remember, we saw Zika as a public health emergency of international concern back in 2016, 2017, because of its link with microcephaly. And as an organization, we need to prepare. And the way that we're doing pandemic preparedness is that we're thinking of this in different ways, but one of the ways we're thinking about this is transmission route. So one of them is respiratory pandemic preparedness for respiratory. We've learned a lot from COVID. We have had pandemic preparedness plans for flu, but we're also thinking of this with arboviruses. It could be Zika. It could be an unknown arbovirus. We call this disease X. We have to prepare for the pathogens that we know about, but also the ones that might emerge. So the long-winded answer to that is yes.
Thank you very much. So I have another question here. Like most of the flaviviruses, the main route of transmission for Zika is through the bite of an infected mosquito. Are there other modes of transmission? Dr. Judith Wong, do you want to take that question? And there is also another question of how do you diagnose Zika virus? Dr. Wong, over to you.
Right. Thanks, Diana. So for the first question on whether there are other modes of transmission, we know that there are, but it's not very often that there would be perinatal transmission and sexual transmission. But I think the main mode of transmission for Zika is still through the bite of an infected mosquito. And the second question is about diagnosis. Sorry, my video isn't working. Yeah, so with regards to diagnosis, the diagnosis is typically through RT-qPCR of a patient sample, typically serum or urine. Thank you.
Thank you very much for your answer. I have a question here for Dr. Sudat from the Southeast Asian region. How CRO is planning to establish surveillance of Zika in the region? Over to you, Dr. Sudat.
Well, at the moment, the Global Arbovirus Initiative adaptation is ongoing, under discussion among the member countries. With that, we will be establishing arboviral surveillance in the region, and also developing a regional dashboard to compile all this data into a single spot. But still the member countries are having so many things to do because of the sporadicity of the cases and also the less prevalent nature of the cases. It is not most of the member countries' priority because they are having a whole lot of other issues to be addressed at the moment. Yes, over to you.
Thank you very much for your answer. I have two questions here for Ricardo. So one, is there any specific antiviral or vaccine available against Zika virus infection? That's the first one. And the second one, is there evidence of microcephaly connected with Zika, particularly in the first trimester, or it can be transmitted in any time of pregnancy? Over to you.
Okay, in relation to vaccine, there is no vaccine available so far. This is why it is very important to follow the community, to develop new diagnostic tools to detect the early possible the circulation of the virus in the community. And in relation to the risk of microcephaly, in the IPD meta-analysis of the Zika Brazilian consortium, which gathered the data of 1,500 women with confirmed RT-PCR Zika virus infection, we found an association of microcephaly. The risk of microcephaly was higher in the first trimester of pregnancy, if infection occurred in the first trimester of pregnancy, which does not mean that a later infection cannot produce microcephaly. Another interesting point is that not all cases of microcephaly were detected at birth. Some children were born with normal head circumference.
I think we cannot hear.
And they developed postnatal microcephaly. So the infected. Could you hear me now? No?
We can hear you now, but we lost you for a few seconds.
Okay, so another, I think that microcephaly may occur if infection at any time during pregnancy, but the risk is higher if infection occurs in the first trimester. And another important point is that microcephaly may not be detected at birth. That there are children that born without microcephaly and they develop a postnatal microcephaly. The brain damage was already there, of course, but the microcephaly becomes evident just during the first year of life.
Thank you very much for that information, Dr. Ricardo. So I have another question here about the clinical presentations of symptoms of Zika are similar to dengue and chikungunya, including fever, headache, arthralgia, retroorbital pain, conjunctivitis, and rash. Is there a definitive clinical algorithm for Zika? I will give the floor to Thais from the PHEIC region to discuss a little bit more how they handle differential diagnosis and how, well, all the research they have done so far about the clinical algorithm for Zika virus. Over to you, Thais.
Thank you. Yeah, I mean, in a context of co-circulation, obviously, it's particularly challenging to discern what is what. So last year, we, as I mentioned briefly, we looked at the evidence and to look at how predictive different signs and symptoms are and how likely they are to occur within comparing Zika versus another arbovirus infection or other acute febrile infections, et cetera. And then we came up with a series of signs and symptoms for Zika, as I mentioned. Those are available online, and I'd be happy to share those as well. I think that we get very few cases of suspected Zika. The symptoms are non-specific, and we've noticed that a lot of the surveillance is focused on pregnancy, as of course is the associated condition of greatest concern. But I'm not sure I answered the question, Diana. I'll pass it over to you.
Yes, you did. So most of the symptoms are very similar. So for the clinician that is in the field that gets a patient with fever and rash or with arthralgia or any of the other symptoms, it's really difficult to know. It's challenging to know exactly which of these arboviruses are, where they are co-circulating, as in most of these endemic countries. So it's key to know the exact case definition and which are the main differences. So for example, for dengue, you see fever is the main symptom and arthralgia and the retroorbital pain. Then with chikungunya, you see a very high fever with arthralgia, severe arthralgia, and more severe arthritis. And then with Zika, as it was mentioned before, the main symptom is rash. So fever is not a high fever like with the other two. Still is challenging. So that's why we need diagnostic tests, and that's why we need to leverage on the molecular diagnostic capacities that were built for COVID-19 to be able to do more molecular diagnosis and disentangle which virus are circulating and which are the viruses that are causing infection in that specific patient. I have another question here for Judith Wong. Do countries send samples out to another country if they don't have the testing capacities? And then the second one, are there teams or companies working towards improving Zika serology specificity? Judith, over to you.
Yes, thanks, Diana. So with regards to the countries testing, I think WHO actually facilitates some of this. As a WHO CC in Singapore, we would also be able to help support some of the testing through WHO. And the second question in terms of the kit evaluations, indeed, under the Global Arbovirus Initiative, we're looking into developing certain ways to do like surveillance, or sorry, not surveillance, but evaluation of the different diagnostic test kits available. Thank you.
Thank you very much for your response. So the last two questions, and thank you very much for all of you that have been engaging in asking questions during the webinar. So the last two questions are for Dr. Ricardo Jimenez. Is there any correlation of Zika infection with autism or as a causative effect? And how do you explain the additional cases of microcephaly during follow-up? Dr. Ricardo, over to you.
Okay, thank you. Okay.
I think we hear you well.
Ricardo, maybe you can try turning off your video to
These are
improve the
two
quality.
important points in relation to autism. Okay. Okay. Can you hear me better now?
Yes, we can hear you. Go ahead from the beginning because we lost you. Over to you.
Okay. Okay. In relation to autism, we do not have this answer yet. There are some case reports of autism in children that are exposed to Zika virus infection during pregnancy, but so far we have no study comparing children born to mothers who were infected during pregnancy with mothers that were not, children born to mothers who were not infected. So this comparison is very important, so we can have a more clear idea if Zika virus infection really increases the risk of autism. So far, we cannot say if there is an association or not, but the studies are being performed. And in relation to postnatal microcephaly, I mean, these children, they are born without microcephaly, but the brain damage, if you look at the image, the brain image of these children, the brain damage is already there, but it did not cause microcephaly. But then during the follow-up, if we follow these children, the brain does not grow as it does in the other children. So it becomes smaller. It's not that the brain becomes smaller, but the microcephaly becomes evident because the brain does not grow in the same speed that it should occur, that it occurs in normal children. Thank you.
Thank you very much for your answer, and I want to thank all the speakers for your participation in this webinar. Now I will hand the floor to our EPI-WIN colleagues. Over to you. Thank you.
Thank you, Diana. Thank you, everybody. As we are coming to the end of our allotted time, I will wrap up by saying thank you very much to all our speakers today, our interpreters, our project managers for the AI interpretation, all WHO colleagues who have worked on this webinar, and the EPI-WIN team, Priya, John Fang, Gabriela, Supriya, and team, overseen by Dr. Sylvie Briand. Finally, thank you to all of you for coming and for your great participation through questions. The recording of this webinar will be available at the EPI-WIN website in the 7 languages of interpretation. And if you want to keep updated on future EPI-WIN webinars, please subscribe to our mailing list. Both links will be appearing in the chat. We hope you will join us for our next webinar on Wednesday, 13 September, on EPI-WIN, on preventing epidemics and pandemics in communities through the One Health approach. Details will be posted shortly on the website and sent to the mailing list. Thank you again.